Hello, I'm Professor Sanjoy Bhattacharya. I teach history of medicine at the University of York, which is in the United Kingdom, and I run the WHO Collaborating Center for Global Health Histories, which works with WHO regional offices, WHO headquarters, and WHO country offices. So today I'm going to be speaking to you about the worldwide smallpox eradication program, which has a long and illustrious history, a history that is very important because this is a history of the only human disease to have ever been eradicated. Now, when smallpox eradication is spoken about, there is sometimes a very simple narrative that is provided. That is one that deals with Edward Jenner's discovery of the smallpox vaccine, the fact that the WHO launched a so-called intensified program of action in 1967, and the fact that after many years of hard work, an international committee certified the eradication of smallpox in 1980. But what I'm going to argue today, and what I'm going to talk about to all of you today, is the fact that the history is much more complex than is commonly thought. In so doing, what I'm also going to argue is that history matters. Carefully researched history is actually of some policy use. What is the important basis for smallpox eradication? The vaccine. For many years, we had a wet vaccine. The wet vaccine was unreliable. It was not heat stable, and therefore, when it was taken into rural areas for vaccination purposes, although the vaccination was carried out, the vaccine was ineffective. But in the 1950s and in the 1960s, what was developed was a freeze-dried vaccine that was relatively heat stable. This immediately improved the situation. What this meant was that this vaccine could be taken into the remotest rural areas of the world where there was no electricity or refrigeration. As long as the vaccine was stored carefully away from direct sunlight, direct strong sunlight, vaccinations could be carried out and the success rates in vaccination went up. Now, in the 1960s, these new types of vaccines were developed in the Soviet Union, the USSR, in East Pakistan and India, and this involved officials working collaboratively in different contexts, but from countries like the Soviet Union, the USA, the UK, Denmark, and later India. Technology transfers of this vaccine production technology increased the number of producers, and soon Pakistan, Indonesia, Yugoslavia, Canada, China, and Brazil were also producing this freeze-dried vaccine, which proved to be a major advance in technology in relation to the smallpox eradication program. But what we have to remember here is that the transfer of technology did not just involve a mere copying of vaccines. All these vaccines were remarkably different in some ways. They were used in different ways, they were packaged in different ways, but most importantly, as vaccine technology was transferred and new vaccines came on board, these vaccines were being given nationalities. Therefore, the Indian vaccine became a source of great pride in India. And although Soviet, American, Canadian, and British vaccine were also in use in the Indian smallpox eradication program, for instance, the Indian vaccine became a mark of great pride and a marker of self-sufficiency. So vaccines and their origins mattered, and we should never forget that in relation to future eradication programs. However, the vaccines were not the only technologies that mattered. What also was greatly important was the bifurcated needle. a simple sewing needle that someone had hammered the head off, creating a sewing needle with a flat head which could be inserted into the vaccine mixture and then introduced, given to people, causing less invasive vaccination scars and wounds. This meant that at one stroke, the chances of post-vaccinal complications were greatly reduced, which in turn ensured that there was less resistance to smallpox vaccination. In this regard, what I would argue is that the vaccine was important, the new vaccine needle was very important, but also what was incredibly important was the hand that held the vaccine. And therefore, without minimizing the importance of the vaccine or the needle technology, what I am arguing here is that the human factor is central to the eradication success story. In the histories that are available to us, we are told that the United States Center for Disease Control, which is based in Atlanta in Georgia, played an incredibly important role in the smallpox eradication program. This is not a lie. US CDC did indeed play an important role globally, whether it was in Western and Central Africa from the mid-60s to 1970, or whether it was in relation to involvement in East Pakistan, which would then become Bangladesh, again in the 60s and 70s, or when they negotiated India between 1967 and 1975, or indeed when they were said to be leading the charge in Eastern Africa, the Horn of Africa, in 1975 to 1979. But what I would like to say is that there were many actors in the global smallpox eradication program. The US CDC was an important part of the global team that eradicated smallpox. There were country-level workers, and then there were other organizations that came in, funded, and assisted smallpox eradication in a variety of ways. So, as a historian of medicine who studies not just the history of technology, but how technologies are introduced into society and social and political responses to the introduction of those technologies, what I'd like to remind all of you is that institutional histories are, by definition, histories of the few. That is, that they try to universalize lessons, histories, on the basis of the views and the memories of a very small number of people. So what I would like to highlight here is the importance of shifting focus. That is, the need and the usefulness of writing the histories of the many. So how do we do that? Here, it's important for me to remind you that for every 100 CDC workers, there were thousands, if not hundreds of thousands, of national and local workers who were looking out for smallpox, vaccinating people against smallpox, isolating people when they still got smallpox, and basically looking after the day-to-day running of an enormously time-consuming and complex project. The WHO itself was not monolithic. It had a headquarters and powerful regional offices. And these powerful regional offices were constantly in conversation with national governments, and through the national governments, local governments. Now, whilst it is true that the WHO and the US CDC would often speak to some government officials and discuss plans and strategies with them, this work was mainly focused in relation to government officials in the national capitals. What the WHO and CDC could not do, due to protocol or just due to the capabilities they had, was to keep in constant touch with local, provincial, or district level workers. So what does this mean? This means that as the smallpox eradication program is going on, there are many conversations that happened. And those conversations often involved neither the WHO nor the CDC. These were conversations between central government, provincial government, and local government officials, where plans were developed, negotiated, and implemented in response to a range of factors that were locally important. Factors like class. How much money did someone have? In India and other parts of South Asia, perhaps, caste, gender. All of this had an influence on how smallpox eradication was implemented and experienced. The many vaccinated communities, and some are represented here in my PowerPoint presentation, were also an important part of the story. We should never forget that. Those who were vaccinated could either pass on good messaging or bad messaging to members in their communities or neighboring villages, which had a direct impact on how societies in disparate social contexts and political contexts responded to smallpox eradication. We, as historians, have to study all those attitudes if our history is to be truly useful to future eradication programs. Now, the other big characteristic in history of medicine and history of science is that it relies on medical heroes and dare I say, medical heroines. Now, what we have to remember as responsible historians doing complex analysis is that individuals can have private views and public views. Public views are always determined by political expectations, political negotiations. Private views often tell us about the complexities, the problems, the negotiations that underpin the completion of a project, whether it's successful or unsuccessful. So in order to better understand the global smallpox eradication program, it is incredibly important not just to rely on the public pronouncements of people, as many historians have tended to do, but also look at the private views and discussions and negotiations, which tell us a lot more about the many challenges of global smallpox eradication, the challenges that were surmounted and make the certification of smallpox eradication all the more extraordinary. So in this PowerPoint that you have in front of you, in the middle of it, you have the picture of Halfdan Mahler, the gentleman who was the WHO Director General at the time smallpox was certified, eradicated. Publicly, he supported smallpox eradication. Privately, he had many concerns. He had concerns that a focus only on smallpox eradication might weaken general health structures. For him, primary health care and universal health coverage was much more important than an expensive battle to eliminate a single disease. If you go anti-clockwise, the next picture shows a visionary man, an amazing gentleman, Donald A. Henderson, with an African colleague looking at smallpox scars in somewhere in Africa. We don't know where. Now, Donald Henderson was publicly supportive, obviously, of smallpox eradication, being the chief of the smallpox eradication unit based in WHO headquarters in Geneva. But privately, he was less confident often than in his public pronouncements. He wondered if the many challenges in South Asia would ever be successfully surmounted. But of course, he could not openly discuss that, because that then would create doubts in the minds of those who were funding and politically supporting the global smallpox eradication program. If you keep going anti-clockwise, we have Nicole Grasse, Dr. Nicole Grasse, an amazing French-Swiss official whose contributions have been unfairly played down, or I would even say in some cases ignored in narrow institutional histories of smallpox eradication. Dr. Grasse was posted in India, in New Delhi, in the smallpox eradication unit that was set up to work in the WHO regional office for Southeast Asia. Here she made friends and she made enemies, as she steadfastly fought to eradicate smallpox, making sure that all political and bureaucratic impediments were removed. As she did this, she veered away from the WHO rulebook. She would often write personal letters to powerful politicians, both within Southeast Asia, but sometimes outside Southeast Asia. She would talk to industrialists. She would talk to local charitable bodies. She would talk to local political leaders not in power. What she was trying to do was to create a coalition of goodwill that would actually create an atmosphere of goodwill that would promote the possibility of smallpox eradication. Nicole Grasse at one point met the head of the then Tata Industries, J.R.D. Tata. The Tatas are a major industrial group in India, and they had great financial and political influence. At a time when the political establishment was more or less disinterested in smallpox eradication, I'm talking about the early 70s, Grasse and her colleagues in WHO were desperate to get political support and some financial support as well. As Grasse explained the situation to J.R.D. Tata and got his support, an unexpected thing happened. J.R.D. Tata used to fund the Congress party that was then ruling India. One of my most exciting accidental findings in the WHO archives in Geneva was a private letter written by hand by J.R.D. Tata to Indira Gandhi, who appears in the last photo as we go anti-clockwise, standing next to President Nixon of the United States. In that letter, J.R.D. Tata explains why he was moved by the WHO's argument for the need for smallpox eradication, and politely but very firmly asks Prime Minister Gandhi, who he refers to as Indira in the letter by her first name, and asks her to provide political support to the smallpox eradication program. Historians had for a very long time wondered why the Indian government, or at least the Indian central government, had so suddenly, from a context marked by disinterest, had suddenly become so supportive of the global smallpox eradication program. That letter from J.R.D. Tata was a turning point, because in that letter he made it clear that if Indira Gandhi wanted to retain his political and financial support for her party machinery, that Indira Gandhi personally signal her support for smallpox eradication. Soon after receiving the letter, Indira Gandhi released to all state governments an order that they support the smallpox eradication program in India, and therefore by definition the smallpox eradication program globally. India had a very large number of smallpox cases. Not having India in the smallpox eradication program meant no global smallpox eradication. Having India on its side, on the other hand, meant that the smallpox eradication program was on track. So once we start studying South Asia, and I study South Asia in the most expansive of ways, in the sense that I define South Asia as including West Pakistan, Pakistan, India, Nepal, Sri Lanka, what was called East Pakistan then became Bangladesh, Burma, now known as Myanmar, the little Himalayan kingdom of Bhutan. These all composed the South Asian subcontinent. The moment you start studying smallpox eradication in South Asia, you basically bring in 1 million more histories. As I said, South Asia housed the largest number annually of smallpox. It lost thousands of people to smallpox every year before the 1970s. There were long vaccination programs in these regions which were linked to colonial regimes beforehand. After independence in the late 40s, there had been reforms to the vaccination programs, but there hadn't been a concerted smallpox eradication program. So in the 1970s, when South Asia came on board, it was, for the history of smallpox eradication, a major, major step forward. Hundreds of thousands of workers became involved in search and containment measures, in vaccination. Here, the complexity came with administrative complexity. Each country in the region had specific administrative structures, political structures, and in the end, those representing the WHO on the ground in relation to smallpox eradication had to deal with all these differences in politics, finance, economic conditions, just bureaucratic practices. So when you look at a region like South Asia, which is incredibly significant for smallpox eradication, you realize that the World Health Organization headquarters was not the only player. There are two other major players directly within the WHO family at play here: the WHO Eastern Mediterranean Regional Office and the WHO Southeast Asia Regional Office. Pakistan was part of WHO EMRO. India was part of WHO CIERO. There had to be regional office cooperation in order to make global smallpox eradication work. India, even though it was in political conflict with Pakistan, had to collaborate with Pakistan in order to control smallpox. After all, infectious diseases do not respect geographical or political boundaries. And in a situation where the disease was seen as a major public health threat in both countries, in that sense at least, global smallpox eradication made political rivals work together, which is fascinating in its own way, but only if one studies smallpox eradication in its complexity and does not reduce it to the actions of a small number of people in one organization. So as we study this history and search for lessons for the future, we cannot do this just with the English languages. What we have to do is to study smallpox eradication in many languages, to study many responses, many innovations, many ideas about how communicable disease programs can and should be run, and how this amazing project came to succeed. Often, from the historian's point of view, if we stop focusing on the published reports mainly written in English and go into the archives, we can find some amazing, amazing information. That information has to be accessed and analyzed in cutting-edge ways. I would suggest that one of the ways one can do this very effectively is to actually go into the field or look at the field reports. Now, these are daily reports being sent by field workers to nations and the WHO regional office. But before they get to the WHO from the government worker on the field, many of these field reports often have to go in languages to a higher up government official. When one sits down with someone who's fluent in that language, that non-English language, and reads a report, and then studies the English translation of that report, which is sent to WHO officials and the central government, one can see a difference. Often these ground reports, these field reports, were not translated in entirety. As translation happened, messaging changed. Why did messages change? Because there were political pressures, there were social pressures, there were institutional pressures. So by recovering the original report and reading these field reports in their entirety, you can actually get a very different picture from the telegram that is, let's say, sent from New Delhi to WHO headquarters. It is in those silences that you can recover the histories of the many millions that I argue are important to study. So my call to you today is that as we study the global smallpox eradication program, or indeed any disease control program, and we try and prepare a history to provide us with lessons so that we can work with policy workers in governments or in the WHO to make health a more transparent activity, make it a more democratic activity, it is incredibly important to recover the silenced histories that relate to those local conditions. What we need to study are interconnected universes. That is not just one country at a time, but about how countries work together. For instance, Brazil played an incredible role in Latin America. As Brazil worked with fellow Latin American countries in trying to control smallpox, it also learned new things and adapted policy and created new innovations for use in the country itself. In the global histories of smallpox eradication that are available to us, especially the ones that are completely reliant on CDC source materials, that is, source materials from the US Centers for Disease Control, there's no reference to the major national and regional programs that were successful and led to the call for smallpox eradication in the first place. I refer here to the smallpox eradication, or indeed what would become part of the eradication program, but what called smallpox elimination programs in the Soviet Union. It was on the basis of the evidence collected from the Soviet Union that the call for global smallpox eradication program was made by the Soviet Union at the World Health Assembly. China carried out its own smallpox elimination policy, initially with Soviet technical and personnel support, and by the time the so-called intensified smallpox eradication phase had been announced by the WHO in 1967, had already driven the numbers of smallpox down to marginal levels. So the Chinese example. Working with the Soviet Union and China in the 1960s were the governments of Inner and Outer Mongolia, and again there were major lessons there. So these are the national case studies that we need to recover. We have to study how these national case studies were linked regionally, how they were the basis for new international cooperations, how there were many forms of internationalisms, and how they were part of the creation of knowledge exchange and technological exchange, often provided free of cost. Scandinavian countries played an incredibly important role in the smallpox eradication program. The Swedish International Development Agency, for instance, played a crucial role in financing the final phase of smallpox eradication. We as historians need to know more about what information CIDA was collecting from actors all over the world at all levels of government about how smallpox was eradicated. Only then will we get a true global history of smallpox eradication. Now I'm sitting here today in Cairo speaking to you about smallpox eradication and its worldwide success. So I have to deal with how WHO EMBRO, the Eastern Mediterranean Regional Office, engaged with smallpox eradication. Now, it is perhaps surprising, and this has been played down in the existing academic work on smallpox eradication, that the WHO EMBRO region was actually deeply connected at all times with the smallpox eradication program. This was through trade, through migration, through pilgrimage. The Hajj, a big congregation of people at a time when countries of South Asia, which sent a lot of pilgrims, were deeply affected by smallpox, a disease that not only scared administrators in the countries of South Asia, but also scared the administrators in the Eastern Mediterranean Regional Office. So what was developed were models of regional cooperation, intercountry cooperation and regional cooperation, where the disease was monitored, where vaccinations were given on a preventive basis, vaccination certificates were checked, and very effective isolation regimes created in case people developed smallpox. Now, it is possible to argue that this formed a crucial part of the global smallpox eradication program. The importance of this work that was carried out during the Hajj in Saudi Arabia is highlighted by an episode in 1972 when a returning pilgrim from the Hajj, returning to then Yugoslavia, to the Kosovo region, returned with smallpox and created what was then considered quite a significant outbreak of the disease. It was a reminder that no country in the world was safe from smallpox, that global eradication of smallpox was important because infectious diseases did not follow or respect political borders. Therefore, South Asia, Africa, Europe were all connected. Indeed, countries like Germany, or rather West Germany to be specific, and the United Kingdom saw outbreaks of smallpox in their own territory, which were brought in by travelers from South Asia, Pakistan and India. This meant that countries like West Germany and Great Britain were actually also supporters of the global smallpox eradication program, because this wasn't just a disease out there, but this was possibly a major public health threat for their own countries. So internationalism takes many forms. The fear of dangerous disease is one major driver of internationalism. Trade was also very important. When the USSR's representatives stood up in the World Health Assembly in late 1950s and asked for global smallpox eradication, they were candid. They said they had eliminated smallpox through routine vaccination in the Soviet Union. However, they argued that the disease kept re-entering the Soviet Union through pockets of infection existing in countries like Afghanistan and Iran. The lesson, therefore, for them, and the lesson they gave the world, was that what was required was concerted international action, that all countries in the world work together to eliminate smallpox, because even if one country in the world had smallpox left, it posed a threat to the rest of the world. However, this work could not be done merely on a bilateral basis. This work required international leadership, and this is where the WHO was important. The WHO provided bridges that allowed governments and countries to work together. The WHO did not necessarily lead the global smallpox eradication program, but it enabled the creation of a coalition of international workers that made smallpox eradication possible. Let's not forget here the other important roles played by the region or countries in the region in the global smallpox eradication program. In the 1970s, when there was the big oil crisis, most of the vehicles that were taking part in the smallpox eradication related work in South Asia started suffering from fuel shortages. Countries like India imported their fuel at that time, and therefore the oil crisis, the global oil crisis, had begun to bite domestic supplies. At that point, our inspirational Dr. Nicole Grasse entered into private correspondence with the Shah of Iran, who also saw the sense in what Dr. Grasse was saying and released huge shipments of petroleum that were then made available to smallpox teams in South Asia. An incredibly important contribution to the global smallpox eradication program, which is often not known about, possibly because narrow institutional histories downplay the role of actors, indeed an actress, like important contributor and actress, Dr. Nicole Grasse. Similarly, we must never forget that the last case of smallpox was in Somalia, that is, a country that is part of the WHO EMRO region. Was it only CDC workers who were working here? Not at all. By the late 1970s, workers with rich experience of working in their own countries and in their own regions were ready to contribute to mopping up the last cases in the Horn of Africa. Indeed, Dr. Isao Arita, an amazing leader, a Japanese official seconded to the WHO, took over the running of the smallpox eradication unit in Geneva. He had himself practiced widely in South Asia and had been personally involved in programs in India and Bangladesh. This was an experienced man, full of ideas, full of energy, with the capacity to mobilize people, who was working very hard with colleagues from across Africa, Eastern Mediterranean Regional Office, the African Regional Office, to make sure that Africa, the continent of Africa, could also soon say that it was free of smallpox. As we look back at that history, we also see other players. Dr. Claudio Amaral from Brazil. He was kidnapped in the Horn of Africa by a rebel army. While in captivity, he convinced the entire rebel army to be vaccinated against smallpox. Dr. Isao Arita negotiated his release. Apparently, on the day of his release, Dr. Amaral came out with a big grin. The first thing he informed Dr. Arita was that the rebel army was successfully protected against smallpox. Smallpox eradication was much more than politics for the people who were staying away from their families, often paying with their health in the very difficult conditions in which they worked. They were an international collective of workers who were there to make a difference. It didn't matter whether they were American, non-American, European, non-European, Indian, non-Indian, Asian, African, from the Middle East. It didn't matter. At that point, all that mattered was an internationalism to get rid of a dreaded disease that had killed many and scared many more. In that sense, this history is very important. Make no mistake about that. The history of smallpox eradication is one that deserves to be remembered. We will soon be celebrating the 40th anniversary of the success in 2020. But what we should not allow to happen is to reduce it to the actions of a handful of people, and that too based in one country. This was an international success. The history of smallpox eradication needs to be equally international. Thank you so much for your time.